Okay, so hello, I'm here on behalf of Beat SCAD, talking to Dr. David Adlam, who's the UK's lead researcher in SCAD. And we're just catching up today following some recent publications. So the first one is published in the Heart Journal, and this is about the risks and benefits of PCI, so percutaneous coronary intervention in SCAD. So I think just to start with, can you tell us a bit about PCI and, how this applies to treatment of SCAD?
So PCI is that set of procedures that we do in patients with coronary artery problems to try to reopen narrowed or occluded arteries. So it's usually something that obviously has been developed to treat that, if you like, conventional or the common form of coronary artery disease, which we call atherosclerosis. And patients who are presenting with an atherosclerotic heart attack, normal practice is to pass a little fine wire down the coronary artery and use that to stretch the artery with balloons, and then stents, which is like a wire mesh tube, to pin the artery open. So we've known for a little while that PCI in SCAD behaves differently to what we normally find in patients with atherosclerotic. There are a higher risk of complications in PCI when it's used in SCAD, the context of SCAD. And also because of the nature of SCAD, which often can be quite long and affect quite small vessels, sometimes you need quite long segments of relatively small caliber stents in order to be able to deal with the situation. And so what we sought to do in this paper was to go beyond a sort of established mantra, which has been around for a few years, that in SCAD patients, conservative management, so not using stents and PCI, may be better. And what we wanted to do is to say, okay, we accept that in lots of SCAD patients where there's good flow in the coronary arteries, that may be the right answer. But what about those SCAD patients who present with a more serious scenario? An occlusion of an artery, a proximal, very tight narrowing of an artery, where perhaps the jeopardy for not doing something to re-establish flow or improve the situation might be greater. And that was, if you like, the aim of the study, was to try and look at this, if you like, more severely affected population. Shall I go on and tell you what we found?
Yeah. Well, if you want to give us just a summary of the study.
Yeah, that's right. So, I mean, essentially what we found is that there's no change in the, if you like, the original advice, which is that patients with lower risk scenarios, with flow in the coronary arteries, more sort of distal, so further down the coronary arteries, little territories that are affected, should be managed conservatively if possible. So that doesn't change. Interventional cardiologists should try not to instrument and go down the route of PCI if that is possible. However, what we have identified is that there is a population of patients with the more extreme end of the spectrum where stenting certainly does lead to improvements in flow in the coronary arteries. So it improves the situation when you look at the angiograms, and is likely, therefore, to improve those outcomes in terms of pumping function of the heart and the long-term outcomes. So I think this is helpful because I think, again, SCAD patients are aware of the things that we talk about as doctors looking after SCAD patients, and it's big. Often there are people that come and see me and will say, look, well, I had stents and that was bad. And actually what we're trying to say here is actually that's not necessarily the case. There are definitely situations where stenting is the right thing to do. And we wanted to get that message out also to clinicians who do stenting, because we don't want the pendulum to swing too far, if you like, in favor of conservative treatment when you've got a more serious scenario, greater risk in terms of the heart muscle, and maybe those cases you should, accepting those extra risks and being aware of those extra risks, but you should still intervene in a careful and appropriate fashion. So I hope that's helpful to those SCAD patients who've had stenting, that essentially what this study shows, that in many of these cases, maybe most of these cases, that was the right way to go for them.
Yeah, I think sometimes patients are looking for that bit of reassurance, you want to know that you've had the right treatment. So I think the findings of the study are certainly provide a bit of reassurance for those that have already had stents. And
That's right.
very challenging for the interventionists for making that decision. So do you feel that this publication will go some way to be helping the interventionists?
I think that's right. I think what we're identifying is when it's the right time to reach for stents. And that's when you've got, very high risk proximal occluded vessels, blockages, where there isn't any flow of blood through them. And so I think it is a question of case selection for interventional cardiologists. But I think that, if you like, what this paper goes a bit further is to say that that's okay. You are allowed in the right cases to make that decision that stenting is the right thing. And also from a patient perspective and also their doctors, I think it's important to say that the medium-term outcomes when we looked at patients with stenting were also very favorable. The scars to the heart generally very small and very good prognosis in terms of outcomes. So this is, I think helps, if you like, to reset the thinking about when to stent and when to manage conservatively. Conservative is definitely best if it's appropriate, but there will always be scenarios when stenting is the way to go. And if that's the case, these data suggest that you can get really good results with good outcomes.
And can you explain a bit about why SCAD patients are, at more risk, perhaps comparable to atherosclerosis?
So it's because the problem in SCAD is that you get this bruise or blood, if you like, in the wall of the artery. So I often say to people that obviously an artery is taking blood to the heart muscle, but your coronary arteries, because they're under pressure, that's blood pressure, they have a thickness, like a tire around them. Because if you had a little thin thing under blood pressure, it would burst. So all of our arteries have this thickness, and within the wall of the artery, this bruise develops and causes compression. But the bruise is rather different from those cells and inflammatory tissue that you get in atherosclerosis. Blood is a bit more fluid and a bit more easy to move. And the challenge in stenting is in SCAD is that when you inflate the stent to displace, if you like, the narrowing that's caused by the bruise, then sometimes the bruise itself can then track along the artery and cause more problems. And that's why you sometimes need more stents. And again, we're starting to learn about maybe some techniques and things which might help the interventionist in those scenarios to minimize or to reduce that risk. We're not as far yet as having data which compares one strategy to another, but certainly there are some things that are emerging that might be useful techniques. And I guess some of that comes along to the next thing we're going to talk about.
Yeah. Well, and also just in terms of, the stents that are placed, and obviously SCAD is a young population in general, young to middle-aged. So having these sort of stents placed at an early age, are there sort of risks there in terms of it being a young population in having the stents in sort of scar tissue building up, for example?
So I think what we should say at the start is that modern stents are really an amazing technology. The longevity of stents in terms of, their long-term outcomes are very good. And that's again shown in this study from the specific perspective of SCAD patients who've had stents. Yes, you can sometimes over a long period of time get furring up inside a stent, but I guess over a long period of time, you can get furring up not inside the stent and get issues related to that. I think what these data show is that in the right patients, this is the right choice at the time of their SCAD, and that once you have stents, even if you do end up with a longer segment of stenting, the outcomes in the medium term, as far as we can see, look to be very good in this population. So I think it's pretty reassuring news for SCAD patients who've had stenting.
Yeah. And this was quite a large study, wasn't it? So it's not just the UK, it was international, and it's quite a large number of patients. So, can you sort of comment on the importance of that high number of participants?
Yeah, I mean, I think it's certainly worth saying from the UK's perspective that these are the kind of studies that we are able to do because of all of the UK SCAD patients who sign that registry consent form. We sometimes get patients who feel a bit disappointed maybe that they're not being invited up for one of the sort of scanning type studies that we've done. But actually, all of the patients who've consented have contributed to this study because we're including over 500 patients, either with stents or without stents, from the UK, from Spain, from Holland, and so on, that we've sort of characterized here. And so even though you're not necessarily coming to Leicester for a scan or something, a specific thing, the fact that you've given us our permission means that we can get hold of your angiograms, we can give you a ring, make sure, see how things have gone with your stents and these kind of things. And that's what's contributed to this paper. And, I think we are now progressing from those initial studies of tens of patients into larger studies of hundreds of patients. And that's obviously important because it means we can look at a bit more detail. And, I think hopefully, several of the things and studies that we've been working on over the last few months and years are like that, getting a bigger, clearer picture of what this means.
And obviously raising awareness of SCAD and educating healthcare professionals, remains a really high priority, and it's a constant ongoing goal, really. So, all these sort of papers obviously contribute to that. So how important is this paper in sort of reaching, target audiences?
Yeah, that's right. I mean, I think this is the biggest paper in terms of looking specifically at stenting in a SCAD population now. It's still observational data rather than clinical trial data. And, we're focused and interested in looking towards that, if you like, goal of clinical trials in the future. But I think this is, these are very important steps forward. Tweet it out. If you're watching this video and you think it's interesting, tweet it out. Let your doctors know. The more people who know about these things, the better. Again, we try obviously to talk a lot to clinical colleagues, medical colleagues, nursing colleagues, paramedics, and so on, just to try and make sure that as many people as possible know about these things and these findings, and therefore can make better choices when they are in that situation in the middle of the night. Obviously, many of our SCAD community have been in that, they go to a hospital and they obviously want their clinician to go, you know what, I know what this is SCAD. I know what the balance of risks is for stenting and not stenting, and for you, we're going to go down this route or the other route. So it's dissemination of this information is hugely important. So as I say, use your social media and get it out there. We're doing the same.
Brilliant. And then the second publication we're just going to chat about is, I guess, again, down the education route. So this is in a PCI medicine textbook. So who reads this? Who does this information go to?
So this is the main European textbook on for cardiologists, cardiology trainees who are in the cath lab. So it's your cardiologists that are doing procedures for the most part who will be looking and learning from this textbook. It's published by the section of the European Society of Cardiology that deals with intervention. It's called Euro PCR. And it's a textbook that is essentially available. It's an online textbook for any trainees across Europe and the world who want to go and learn about the whole spectrum of cardiology. And so this is, I think, the first chapter dedicated to SCAD in any textbook of this sort. You're going to get little sections, a little paragraph, this kind of thing, a little mention at the bottom of page 3127. And that's, if you like, been one of the challenges with SCAD is that, often it has been too much of a footnote and is not getting enough attention. And I think the work that many people are doing internationally and the Beat SCAD community and the research that's funded by you is contributing hugely to this increase in awareness. And I think this is a chapter, it's comprehensive. I can't remember how many pages it runs to, but it's, more pages than I have years. I'm only 21, of course, but substantially more pages than I have years. And I think, it details all of these things. It talks about the PCI paper that we've just talked about. It talks about other research that has been conducted across the world, Mayo Clinic and in Vancouver, and the other fantastic groups who've been doing so much over the years to progress our understanding of this condition. And I think, again, what we really hope is that it's a go-to textbook, both for people to learn, but also for people to dip into. So that, if they're there in the middle of the night and they're thinking, goodness, SCAD, I heard that Dave Adlam bloke 20 years ago talk about this, but I can't really remember it now. They can go in there. This is a textbook that will be continually updated.
Okay.
So we will go back and we will say, new study comes out, we'll go back in a year or two and we'll update it and we'll say, look, there's new information, new data in this area that we think should influence how you practice things. So the idea is it's a kind of continuously up-to-date chapter on SCAD that, anybody who's part of that EuroPCR, and obviously huge membership of the European Society of Cardiology and EuroPCR, that they can dip into that and learn about their particular scenario.
Yeah, that's great. Because obviously at Beat SCAD, one of the areas that we were trying to focus on in terms of raising awareness and education is trying to get SCAD into guidelines for healthcare professionals. We've sort of been trying to target NICE guidelines because, they're national in the UK, but, that's obviously very, very challenging. But it's great that there's these other textbooks. We've kind of been communicating with paramedics about how to try and get information into their training resources. So are there any other sort of textbooks similar to that you would be trying to get published in, or, are you happy that this is a key one to keep updating?
Yeah, I mean, I think this is a key starting point, but we are happy and available to contribute to whatever resources we can to get more information out there. Really, I think this is important because of its scope, if you like. It is a European target audience, which is substantial. I mean, it goes beyond Europe. It's obviously the ESC and the American Heart are the two sort of big global leaders in this area. So you're right, it's an ongoing thing. I think we've got a nice bit on SCAD in some of the more recent European guidelines, but we still have a direction to go to raise awareness, get a proper prominence, to make sure that people out there who are reading the guidance are aware that SCAD is different, as we've just been talking about in terms of PCI. And it's obviously really important that those messages get out there.
Yeah. And I'm sure you're all still busy doing analysis work and writing things up. So what's next on the publication list?
So hot off the press is that we have a paper that has just been accepted. It's not yet published online. I would think it will come out in the next 2 or 3 weeks, probably, in Cardiovascular Research, which is a very high quality journal, one of the European Heart Journal family. And it's a paper that's looking a little bit more about the why questions. Why is it that SCAD happens? Is it because of, we've looked at a few different hypotheses. Again, contributors from different places this time. So we've used both, we've been looking at connective tissue from biopsies from skin, and some of our SCAD patients and amazing healthy volunteers agreed to give us a little bit of their skin so that we could have a look under the electron microscope, so really high resolution at the connective tissue. And what that showed is that there are no, if you like, very large changes in the connective tissue. Most of the things, the fibers look very similar. They don't look like they're sort of broken or frayed or damaged in an obvious way. This is perhaps not surprising. It suggests that the things that we need to look for are more subtle, maybe more localized. Maybe they're not there all the time. So interesting things. But what we've demonstrated is that there isn't a sort of fixed abnormality of the connective tissue. Maybe some subtle things, but definitely the numbers of fibers, the size of the fibers, those kind of things look very similar. And the other thing that we've done is we've looked at a population of patients from globally, from Australia, from the UK, and from Holland, who have not survived SCAD, sadly. And these are very rare, which is why we needed to go internationally to be able to look at these small number of cases and to look at the cells around the coronary arteries under a high resolution microscope, again, to try and understand, is SCAD caused by inflammation of the arteries, or is there some change in the nature of the little tiny microvessels around the coronary arteries? And what we've shown here is that there are those changes, but those probably occur in response to the SCAD injury rather than as a cause for the SCAD, if that makes sense. And we've also looked a little bit at the question as to whether SCAD is caused by pre-existent fibromuscular dysplasia, and which you probably remember is the thing that one of the things that we look for in the other arteries of the body, and we wonder, is there something like that going on in the coronary arteries? And as a, if you like, a pre-existent cause for SCAD. And what we've shown here is that certainly it doesn't seem to be that that's the case in every case. There may be some cases where that is an issue, but it doesn't seem to be, if you like, the overarching explanation as to what's happened in SCAD. So these are things which help us, because the nature of understanding any disease is that you have to form ideas, and then you have to test those ideas to see if you're right or wrong. And if you're right, that's great, you can go down that route. But if you're wrong, it helps you to refocus and think again about different directions and different ways to look at, if you like, more subtle underlying explanations as to why this vulnerability occurs.
Sure, so excluding things along the way.
Exactly, yeah. Exactly.
Great. And how about the work that Dr. Alice Wood is doing? So obviously her clinical fellowship will come to an end in the summer. And so she'll be very, very busy, I'm sure, writing all of that up at the moment. So, when would we expect to hear news from her findings?
Yep, so Alice is under her own unique lockdown, a data lockdown, if you like. So she is busy at the moment looking and analysing all of these, the data that she's collected. So it's too soon to say, exactly what the answers are. Part of the reason for that, by the way, is because in order to try and make these analyses really robust, what we try to do is we try to keep ourselves as researchers blinded, we say. So we're not looking at the data as we go. You might think we kind of keep analysing it and see where it's going. And it's tempting to do that. But the challenge is that if you do that, sometimes you're kind of tempted to tweak it in a little direction, even subconsciously or another. So what we've done with this is that we've essentially made sure that nobody knows when we're comparing one scan to another. Nobody knows if it's a SCAD scan or a healthy volunteer scan. And so Alice has done all of this analysis without knowing which cases she's looking at. And so once all of that analysis is done, we'll then have, if you like, the sort of ta-da moment where everything gets unblinded, and then we can have a look. And as I say, the advantage of that is that if there are differences, it's much more convincing that those are real things rather than things which have sort of emerged as a consequences of the way that we've analysed the data. So, I think we're all looking forward to finding out what that shows, whether it gives us, some of those hints that we were just talking about, where we should be going next up. So, there's lots of stuff going on at the moment. We're also continuing to work with our international partners on the genetic side. So we hope to have some more news on that front later in the year as well. So we're keeping busy.
Yeah, still a lot happening. It's really great. It's very encouraging as well.
Yeah. And I think, as I said a little moment ago, just a message to all of our volunteers, whether they've been healthy volunteers or SCAD patients and their families, a huge thank you to all of you, because without you, we don't have any of these data that we can analyze. And so we're not able to, put these papers out, and take those little itty steps forward with SCAD, which I think hopefully now, if we look back and see where we were sort of 5 years ago and look where we are now, you can see that all of those little itty steps have added up to, quite some substantial steps forward.
Absolutely, yeah. And on behalf of the SCAD community, I extend thanks to you and your team and all your efforts, especially all the collaborations, because you know, that's what's bringing a lot of the information as well, this collaboration. So so thank you.
Well, we couldn't do it without Beat SCAD, because, you know, you are the funder of the research. So, you know, hopefully, you know, in some respects, many congratulations to you and your team and all of your patient supporters.
Thank you. Thank you for talking to me today. I look
Great.
forward to catching up with the next publications.
Excellent. Bye now.